Shall I start, ma'am?
Yes.
Okay, ma'am. Good evening, honorable present here. Now I'm going to present a case on cephalopelvic disproportion. I'm Dr. Shruti, final postgraduate of Chengalpattu Medical College. A 30-year-old Mrs. X, resident of Chengalpet, clerk by occupation belonging to socio-economic class 3, primary gravida, booked and immunized at Padaram PHC. LMP was 2/6/2025 with regular cycles, and EDD was 9/3/2026 with gestational age of 39 plus 4 days. She is a primary gravida with 9 months of amenorrhea with 39 weeks plus 4 days of gestation, admitted with lower abdomen pain for the safe confinement. History of presenting
So we
illness.
first previous page.
Yes, ma'am.
Okay. So what all will you do while booking relevant to our case? So
Booking,
during the booking
we have to
visit,
assess the patient height, ma'am.
what all you'll do during booking visit?
On booking, seeing for the height and weight, ma'am. Hello, ma'am.
Yes, ma'am, you proceed. You told so on booking you will be seeing height, weight, then
Injection
only
TD.
not. That's all.
First dose of injection TD,
Huh?
ma'am. Injection first dose TD, ma'am. Blood grouping typing HIV,
So
VDRL,
without confirming pregnancy, we go for TD injection, huh?
UPT,
UPT has to be done, ma'am.
Then
dating scan, is
yes.
intrauterine ectopic,
What all you look in dating scan?
CR,
CRL,
GSAC and CRL, ma'am.
Hmm.
And have to assess for the other adnexal masses or adnexal lesions.
So five things you have to look at the booking scan. Okay.
Okay, ma'am.
And then why we have to do that booking scan? So we have to confirm her gestation age. That will be helpful for the expected age EDD calculation. Okay. So when you say as a best days or good days and it is bad days.
Patient is having regular cycles. She's not on any oral contraceptive pills for the far past 6 months, ma'am. And the patient is
Yes.
sure of date.
Yes. One criteria is patient is sure of her dates, then not on OC pills,
Not
then
on. Patient is having regular cycles, ma'am.
yes, then best dates are said to be when. Another criteria is the patient should have done an ultrasound before at about 16 to 20 weeks.
Yes,
Okay,
ma'am.
so all correlating giving the same EDG. Okay, so when you
Okay.
say as good dates, these are said to be best days. Okay, when you say as good dates,
CRL
or
correspond.
when the patient has irregular cycles, but she had done ultrasound, okay, that shows the same EDD is said to be good dates. Okay, or when the patient has done an ultrasound after 24 weeks, two ultrasounds correspondingly says the same date is said to be the good dates. And when you say as a bad dates, patient has irregular cycles and then having an ultrasound after done only one ultrasound after done at 24 weeks, it is said to be a bad dates. Okay, so these are all important for calculating the EDD and for delivering her. Okay,
Okay, ma'am.
so on booking visit, you will do a height and weight measurement. Okay,
Yes,
Yes, ma'am.
ma'am.
does the and the patient was categorized as high risk or low risk during the booking visit itself. Is it not?
Yes,
So
Yes,
ma'am.
our
ma'am.
patient comes under which criteria? High risk or low risk?
Our patient comes under the criteria of uh, low
What
risk,
are the
ma'am.
factors? High risk or low risk? So you said booking visit. You have to write in detail what all done in the booking visit and whether she was categorized as a high or low risk. Okay, that has to be added. Okay, so how she was categorized? High or low?
Low, ma'am.
Low risk, ma'am.
Low risk. So what are the things to say as low risk here? What are the points to say as low risk here?
Um,
Regular menstrual
You have to
cycle.
substantiate what may be your answer, no?
she's a primary gravida with 9 months of amenorrhea with no other.
No other co-mobs, ma'am.
Hmm.
Primary gravidara, ma'am.
So
Height
after
is
her examination also she comes under low risk?
No,
no,
ma'am.
ma'am.
After the examination, patient comes under the high risk of short primary, ma'am.
That you have to mention, no? Her height is less than, what is the height?
If the height is less than 140 centimeter,
145 with Indian criteria.
yes, ma'am.
What is your opinion, Dr. Kartika? 145 only, no?
Yes, ma'am. 145 only we take as cutoff.
145.
Okay, ma'am.
So
For our
whether she was categorized as high risk or low risk, ma'am?
high risk,
High risk,
ma'am.
no?
Our patient
What
is
is the
height is 141 centimeter, ma'am.
141 centimeters? So booking research itself, her grades was good and her LRP is correct, and her EDD is reliable. And the thing is, high risk comes to our mind is only the height. Is it not? So, on
Yes,
the
ma'am.
first visit result, we have to categorize like that. Okay.
Okay,
Yes,
ma'am.
ma'am.
Move on to the second page. Move on to the second page.
History of presenting illness. Patient came with the complaints of lower abdomen pain for a duration of 3 hours, intermittent dull aching in nature, not radiating to the back and thigh, not increasing in frequency, duration, and intensity, relieved on taking rest, and able to perceive fetal movements as well, ma'am.
Next page.
No history of leaking per vaginum, no history of bleeding per vaginum, no passage of show, no history of nausea, vomiting, constipation, no history of fever, burning menstruation or urinary complaints, no history of trauma or recent intercourse, no history of headache, blooding of vision or epigastric pain, and no history of foul smelling vaginal discharge. Marital history.
So previous page.
What do you
Previous
think
page.
as the cause of pain
Previous
here?
page.
What do you think as the cause of pain?
So you have elicited the present history. So from this, what is your conclusion about the cause of pain? As Madam Kartika, Madam have asked.
It is false labor
Swelling
pain,
pain.
ma'am.
How you say as false labor pain? How you differentiate between a true and a false labor pain? And what is the gestation age?
39
39
plus
plus
4
4
days,
months.
ma'am.
Okay, we will come to later. Okay, so from this, what is the conclusion? You have come to a conclusion, no? What is that?
It is not radiating to the back or thigh, and it's not increasing in frequency, and is also relieved on taking rest, ma'am. There is no evidence of cervical dilatation, and there is no passage of show.
Okay,
Due to
proceed.
contraction.
So from this, you say as false labor pain.
Yes, ma'am. There
Is
is no
it not?
rupture of membranes or descent
So,
of the presenting part.
what is the true nature of the true labor pain?
The true labor pain will be associated with changes in cervix and associated with show, which will be radiating to back and thigh. And this increases in frequency and duration, ma'am. It is not relieved on taking rest.
Where the site will be? Site of pain, you have not mentioned. Site of pain, where the pain will be.
Low back pain, ma'am.
Lower abdominal, and the low back ache pain.
Yes,
Okay,
ma'am.
radiating to the
Thighs.
Thighs.
inner thighs. Okay,
Yes, ma'am.
okay, next.
Marital history. Married since 3 years. Non-consanguineous marriage. Living with husband. After 1 year of marriage, she was evaluated for infertility and has taken 3 cycles of ovulation induction and now conceived spontaneously. Menstrual history: attained menarche at 14 years of age, regular cycles, 3 by 28 days cycles, changing 1 to 2 pads per day, not associated with passage of clots or pain, and LMP was 2/6/2025.
So
Obstetric
from
history.
this, her cycles are regular and reliable.
Yes,
Okay,
ma'am.
her ED is reliable. Okay.
Yes,
Okay,
ma'am.
next. More techniques.
Obstetric history: a first trimester, spontaneous conception after 3 years of age, 3 years of marriage. Urine pregnancy test was done at 5 weeks of amenorrhea, and pregnancy was confirmed by ultrasound at 6 weeks. Injection TD first dose given, folic acid tablets were taken. All blood investigations done and said to be normal. No history of excessive vomiting or fever with rashes. No history of drug intake or radiation exposure. No history of pain abdomen, bleeding or spotting PV. NT scan was done and was found to be normal, ma'am.
And normal and was corresponding to her ED. Is that
Yes,
not?
ma'am. Yes, ma'am.
Next.
Second trimester, patient was on regular antenatal checkup. Quickening was felt at 20 weeks. Anomaly scan done was said to be normal. Prophylactic iron and folic acid and calcium supplementations were taken regularly. Immunized with second dose of TD. Blood pressure and OGCT was said to be normal. No history of pain abdomen, bleeding or leaking PV. No history of headache, blood ring of vision, epigastric pain or decreased urine output. No history of increased appetite or increased thirst or increased frequency of micturition. On third
Next.
trimester, fetal movements were perceived well. No history of headache, blood ring of vision, epigastric pain or decreased urine output. All BP recordings and blood sugars estimated was found to be normal. She took prophylactic iron and calcium supplementation regularly. Interval growth scan was done and found to be normal. No history of pain abdomen, bleeding or leaking PV. Past history: no history of diabetes, hypertension, thyroid disorders, tuberculosis, asthma, epilepsy, heart disease, and no history of tuberculosis of hip, pelvic joint, spine, no history of poliomyelitis in childhood, no history of nutritional disorders in childhood, no history of fractures in spine, pelvis, or lower limb, nil past surgical history, ma'am. Personal
So
history.
patient has a height of 141 centimeter. Is
Yes,
it so?
ma'am.
What all the complications or discomfort you expect during the antenatal period, first, second, and third trimester? Elaborate on. You
Um,
have told the antenatal first previous slide for me.
yes, ma'am.
Okay, first, second, third trimester. So, what are the complications or the difficulties a woman may face when her height is 141 or in her height when she is a short stature? What are the discomfort patient may encounter during the first, second, and third trimester?
During the
First trimester, does it have any impact?
no, ma'am.
No. Second trimester,
Second trimester,
Excessive weight gain, ma'am.
excessive weight gain, bilateral pedal edema, ma'am.
excessive weight gain, is it relevant to our case? No, no, it's not like that, na? Pedal
Patient
edema, okay.
pedal edema,
Third
ma'am.
trimester, third trimester,
The patient will be having
third trimester.
mm, bilateral pedal edema and pendulous abdomen, ma'am.
Mobile head. Head mobile, ma'am.
Floating head. Patient complaints. Excessive lumbar lordosis, ma'am.
Waddling gait, ma'am.
Hello, ma'am. Hello.
Ma'am, you're on mute. Tenmoli, ma'am. Ma'am, you're on mute.
Yes, yes. Yes, madam. Yes, madam. Okay. So the patient will be having a excessive lumbar lordosis causing low backache, and then respiratory embarrassment will be more. Okay, difficulty. Okay, and difficulty in walking.
Yes,
So all
ma'am.
these things she'll be experiencing. Okay, apart from that, because of the baby will have a very small space to enlarge, no?
Yes,
Yes,
ma'am.
ma'am.
It may be associated with IUGR, preterm labor, PPROM, prematurity. So these are the complications a patient may have when there is short stature.
Okay, ma'am.
Okay,
So a
so the
patient is a
patient,
primary gravida. Suppose she is
Yes,
a
ma'am.
previous, she's a multiparous woman. Then what other history you will elicit from the first pregnancy?
Ma'am,
Prolonged
prolonged
labor,
labor,
obstructed
obstructed labor,
labor.
and any neonatal death or stillbirth and fetal asphyxia, ma'am. Whether she has gone any undergone operative vaginal delivery.
So most important is what was the whether she has underwent normal delivery or instrumental or
Instrumental
cesarean
delivery.
section. So
Yes,
if it is
ma'am.
cesarean section, you have to know the indication for cesarean section.
Section.
Okay. Suppose she has underwent normal delivery, you have to anticipate any intrapartum complication she has experienced. So
Yes,
that
ma'am.
history also should be elicited in detail. Okay.
Okay, ma'am.
Suppose any instrumental delivery she has underwent, again you have to ask whether there was any difficulty in instrumental delivery, maybe was in NICU care. Those details you have to elicit. Okay.
Okay, ma'am.
Can continue.
Yes, ma'am. Personal history consumes mixed diet, normal appetite, normal bowel and bladder habits, normal sleep and appetite. Family history, no history of diabetes, hypertension, or tuberculosis. On general physical examination, she's short stature with height of 141 centimeter and pre-pregnancy weight of 60 kg with a BMI of 30.2 and the present weight is 73 kg with a total weight gain of 13 kgs. Patient moderately built and nourished, no pallor, not icteric, no cyanosis, clubbing, pale edema and lymphadenopathy, no deformities of spine. Breast and thyroid examination was found to be normal. Gait is normal. Vitals, BP 120/70 millimeters of mercury in left upper limb in the sitting position. Pulse rate was 90 per minute, regular, normal in volume, felt in all the peripheries, no radiofemoral delay. Temperature, afebrile. On systemic examination, CVS, no murmurs, RS, normal vesicular blood sounds with no added sounds. On CNS examination, no focal neurological deficit. Obstetric examination on inspection after getting consent from the patient after bladder emptying. Abdomen was exposed from Ziffy sternum to the pubic symphysis. Patient examined with dorsal position with the semi-flexed thighs. Abdomen is longitudinally distended, flanks full. Abdomen is longitudinally distended, flanks full with umbilicus midline and flushed with abdomen. Linea nigra stria gravidarum seen. No scars, sinuses, dilated veins, or hernial orifices free. On palpation,
Before you proceed further, so when a patient walks in, a
yes,
short
ma'am.
stature patient walks in, so what points will favor she may be having CPD?
Waddling gait, ma'am.
Pendulous
Waddling
abdomen?
Pendulous abdomen.
with pendulous abdomen, ma'am.
Yeah. Okay, continue palpation.
Yes, ma'am. Fundal grip, broad, soft, independently palatable mass, breech felt. Umbilical grip, left side smooth, curved, uniform, resistant spine felt. Right side multiple limb nodules felt. First pelvic grip, hard, round, head 4/5 palpable. Second pelvic grip, findings of the first pelvic grip were confirmed, head unengaged and well flexed head. Uterus was found to be relaxed and clinically adequate like a fundal height corresponds to 32 weeks of gestation with flanks full. Symphysia fundal height was 32 centimeter. And abdominal girth is 96 centimeter with estimated fetal weight of 3.1 kg, ma'am. On
how
auscultation,
you calculated the estimated weight? How you calculated the fetal height weight?
based upon the Johnson's formula, ma'am.
Tell us the Johnson's form.
The symphysia fundal height minus 12, 155 grams.
So you know the formula, Johnson's formula. So for engaged head, it's a different formula. For unengaged head, it's a different formula. Okay.
For engaged head, it is symphysia fundal height minus 11, ma'am. For unengaged head, it is symphysia fundal height minus
12,
12.
ma'am.
Okay. So in her palpation, what are the findings which tells you that she is having cephalopelvic disproportion?
4/5
Head is
of the head
4/5
is palpable, ma'am. The head is unengaged.
Hmm. Any other way you
When
can make
you
out?
when you expect a Rainy have an engagement of the head occurs. In case of Rainy, when the engagement occurs.
Cross 37 weeks,
ma'am.
ma'am.
A term, ma'am.
37. What do you mean by term? 37 is yearly. The
Late.
book says
38 weeks, ma'am.
38 37 completed weeks
2
or
to 3
38
weeks
weeks.
prior to labor.
Yes, ma'am.
Okay, you expect the patient, the head to engage during that. So, what are the findings when the patient has this short priming? What are the abdomen findings will be there?
In case of CPD at the level of inlet,
So,
floating head.
when the patient has that is 140 centimeter, no, 141.
Yes,
141
ma'am.
centimeters.
Then how could it be 32 weeks gestation? So it will be more than the period of amino there, because of a short stature. Is it
We have
not?
told head is not engaged, no? That means head is above. It has not gone inside the pelvis, right?
Yes,
So
ma'am.
what are the causes of delayed engagement in the case of priming? There are about 10 causes for the delayed engagement in priming.
It can be because of full bladder, ma'am.
Wrong
Hmm.
dates,
Wrong dates.
any
In case
placenta
of placenta
previa,
previa,
tumors,
polyhydramnios, ma'am. Multiple pregnancies and tumor complicating, which is in the either in the lower
lower uterine
uterine
segment,
segment
ma'am.
or fibroid.
First thing should
Our
come is
case,
scapulopellae
CPD.
disproportion, no?
It's CPD,
Your
no?
case.
Our case, you
Pelvis
looked at.
dislocation. Yes, ma'am. Yes, ma'am.
So you have to tell first common things before you tell uncommon things.
Okay, ma'am.
So how you will know head is engaged or not? What are the findings which will tell that head is engaged?
Ma'am, if the head is engaged, less than 2/5 of the head will be palpable, ma'am. And in the pervaginal examination, the station will be at -1 to 0, ma'am.
Okay.
When a patient head engages at multi,
At the onset of
onset
labor,
labor, ma'am.
ma'am.
at the onset of labor and after membrane rupture. Okay,
Ruptures. Yes, ma'am.
proceed, proceed now.
Yes, ma'am. On auscultation, fetal heart sounds heard at the left spinal umbilical line below the umbilicus, and the fetal heart rate is found to be 142 per minute, which is regular in rhythm. On local examination, external genitalia normal. On pervaginal examination, cervix soft, posterior 3 cm long, os closed, head at -3 station. Sacral promontory could not be reached at ease. Sacrum is well curved above downwards and from side to side. Sacrosciatic notch admits 2 finger. Side walls parallel. Spines not prominent. Both the spines could not be touched simultaneously. Subpubic arch wide admits 2 fingers. And the intertuberous the distance admits 4 knuckles. And the Muller method, as per the Mundroker-Muller assessment, was mild CPD elicited, ma'am.
So sacral promontory could not be reached, you have mentioned. What it indicates?
It is
Gynecoid pelvis, ma'am.
there is
What it
no
indicates?
CPD at the level of inlet, ma'am.
So what you are measuring actually?
Diagonal conjugate,
Conjugate, ma'am.
ma'am.
How will
The
you
normal
measure?
from the lower border of the pubic symphysis till the center of the sacral promontory, ma'am.
So what is the normal measurement?
12.5,
12.5,
ma'am.
ma'am.
Normally, whether you will be able to touch the sacral promontory?
No,
No,
ma'am,
ma'am,
not with
not with
these,
this, ma'am.
ma'am.
Okay, so indirectly what we are measuring? So you are measuring diagonal conjugate, but actually what it measures?
Obstetric conjugate, ma'am.
So how you can get the obstetric conjugate?
On subtracting
On the
1.5 to 2 centimeter
centimeter
from the
from the
diagonal
diagonal conjugate.
conjugate, ma'am.
Okay, so that you are measuring the inlet. So you are assessing the inlet, right?
Yes, ma'am.
So we are going to assess the cavity.
Cavity has to be assessed at the
Interspinous
level of
diameter.
the ischial spines, ma'am.
Intervisual spine diameter, ma'am.
So normally what is the diameter measurement?
More than 10 cm, ma'am.
So if it is less than 8, it indicates
Contracted pelvis,
ma'am.
ma'am.
well, it's only you will see the interspinous diameter or anything else you will assess for cavity.
No, ma'am,
So you have put in the
interspinous.
slide, but you're telling only one point. So you have to tell everything, no?
Yes,
Sacral
ma'am.
curvature, side walls parallel,
And
sacroiliac
sacrosciatic
notch, all
notch,
those
ma'am.
things indicates cavity.
Yes, ma'am.
Outlet?
Outlet is the subpubic angle and the intertuberous
Tuberous
diameter,
diameter,
ma'am.
So what should be the normal subpubic angle?
More than 90 degrees.
So indirectly what we tell? So you'll measure angle or something else you will do. So you have to
Ma'am,
put
we'll
two
insert
fingers.
two fingers
Fingers is
inside,
good,
ma'am.
ma'am.
If it
When
admits
the
two
subpubic
fingers,
touch. So if you are easily able to do that, then it is more than 90 degree.
90
Right?
degree, ma'am.
Then you have to see this
Intertuberous
Diameter.
distance by admitting
intertuberous
the
diameter. So it should allow
four
Four
knuckles,
knuckles, ma'am.
ma'am.
4 knuckles. Okay, so this you are seeing for the outlet.
Outlet, ma'am.
So inlet, cavity, and outlet.
Outlet.
So what does Mantroker-Muller method? Explain it. How will you do?
Ma'am, in Mundroker-Muller method, left hand over the head, ma'am, fetal head, and in right hand, middle and index finger to the PV examination in the one of the ischial spine, ma'am. The head of the baby is pushed downwards. It hitches into the index finger. It is a no CPD, ma'am. It flushed with the right hand of
Actually, we'll do a bimanual examination. With thumb should be over the pubic
the
pubic
pubic
symphysis
symphysis, ma'am.
and 2 fingers should be inside. Then you will be pushing the head with the left hand. So
Yes, ma'am.
if you are able to push it up to the fingers, it indicates what?
There is no
No degree
CPD,
of
ma'am.
CPD, ma'am.
If the head flushes
flushed
with
with
the
the
pubic symphysis with the thumb, that is a
Mild
minor
degree
degree
of
of
CPD,
CPD.
ma'am.
If it overwrites, then there is a major degree of CPD, ma'am.
So this is one method, Mantroker-Muller method, which is a bimanual examination.
Yes,
So
ma'am.
abdominal palpation also there is one method. What is that method called?
On abdominal palpation, there are Ian-Donald method and Chasser-Moyer
method.
head fitting method, ma'am.
So what is that?
Chasser-Moyer head fitting method is the left hand should hold the fetal head, fetal head, ma'am, and the right hand, the index and the middle finger has to be placed over the pubic symphysis. On pushing the head backwards and downwards, if the head goes inside the crosses the pelvic brim and gets inside, there is no CPD. If it flushes with the pubic symphysis, there is mild CPD. If it overrides the index finger pubic symphysis, there is major degree of CPD, ma'am.
So when will you do the assessment? Cephalopelvic disproportion assessment?
For primary in 38 weeks.
37 completed weeks, ma'am.
Okay. Is it advised now? Is it
No, ma'am.
totally-
The best method is to see the onset of labor, ma'am.
Yes. Okay, proceed.
Okay, ma'am.
Chasser-Moyer, have you explained how Chasser-Moyer is done?
Yes, ma'am.
You told her?
Yes, ma'am.
Okay, move on.
Yes. A 30-year-old Mrs. X, primary gravida with regular cycles, with LMP 2/6/2025 with EDD of 9/3/2026, gestational age of 39 weeks plus 4 days, conceived spontaneously after 3 years of marriage, booked and immunized, had complaints of lower abdomen pain and able to perceive fetal movements well. On examination, she is short stature of 141 centimeter with a single fetus in longitudinal lie with cephalic presentation with unengaged head and clinically adequate liquor and good fetal heart rate admitted for safe confinement.
So when the patient comes earlier, how you plan for her delivery? So patient reports to your college, tertiary care
Okay.
center,
Yes,
reports
ma'am.
to you earlier. So in like second trimester like that, no? How you plan for delivery? Is it the way the patient has to get admitted or something else? How you plan for delivery?
If the patient is having any other comorbidities, we can go for
Other comorbidities, your patient, not this patient.
this patient.
No comorbidities, but her height is 141 centimeters.
No need for early admission, ma'am.
What complications can happen
How
if
you
there is
plan
major
for delivery? That's all. What are the instructions you have to give? How you counsel her for delivery? Everything you have to tell. You're a consultant, no?
Yes, ma'am.
You're a consultant. You have to plan for delivery.
We have to tell the patient about the trial of labor.
When you, how you plan, then you have to what instruction you have to give her.
If there is any, if she's having any pain, or
So
if there
when you
is
are, as previously discussed, when you go for the CPD assessment,
at 37 completed weeks, ma'am.
so 37 completed weeks or 38 weeks. So in case of primary and the patient with BOH, we have to assess her pelvis by CPD assessment, not pelvic assessment. CPD assessment by the 37 completed weeks at start of 38 weeks. Okay.
Okay,
So
ma'am.
when there is mild CPD like this, now she has to be counseled and you have to get admitted at 38 weeks because she can go to a labor at any point of time. And what are the complications we have discussed earlier? No, what are the complications we expect during the labor in the parents patient is I have an unengaged head or mobile head like that, na?
There can be
Premature rupture
malpresentation,
of
ma'am,
membrane, ma'am.
and earlier rupture of membranes. It has increased the risk of cord prolapse. And there are prolonged labor, ma'am, or arrest of labor,
Obstructed labor.
and increased chances for instrumental delivery and perineal tears, and possibilities of cesarean section has to be explained, ma'am.
Infections
The
also, prolonged labor. So they
Prolonged
can
labor.
go for infections also.
deflexed head you may also expect a deflexed head. Okay,
Yes, ma'am.
so that has to be evaluated by the during the abdominal examination itself. Okay, so how a deflexed head is evaluated?
The sinciput will be at the lower level than the occiput, ma'am.
Mm.
How will you evaluate them?
That is an extended head. So by the relative position of the sinciput and occiput, you'll be evaluating the attitude of the head.
Yes,
Okay.
ma'am.
So you have to admit with 38 weeks, and then you, as you said, it is you have evaluated the pelvis, and it was a mild CPD. Okay, so
Yes,
then
ma'am.
what is your plan of action?
We have to counsel the patient about the trial of labor, ma'am.
Where you will conduct trial of labor? What
It's a
facility
double
should be
setup,
there?
It's
ma'am.
Prerequisites.
It's a conduct
Double
of
set
labor in a borderline CPD in an institution with expectancy of
obstetrician and
op-
pediatrician.
obstetrician and pediatrician, ma'am.
OT setup, ma'am.
Okay, everything has to be counseled to the patient. Okay, so
Yes,
with the
ma'am.
what is set up, it should that should be prepared for cesarean section. Okay, preparation should be adequate for the cesarean section. So there only you can conduct a trial of labor. So the definition of trial of labor is what is the definition of trial of labor?
Conduct of labor in a borderline CPD in an institution.
With the
Mm, wi-
adequate liker with the adequate size of the baby, ma'am.
Adequate lighter is not doesn't come under the definition. So in an institution where the emergency cesarean can be done. Okay. So what about your patient? How long you'll wait, or you want to induce?
no, ma'am, no need for induction in this analysis.
Why no need of what is
LLM
the criteria for a trial of labor? There should be a spontaneous onset of labor.
labor.
So there is a controversial whether go for induction or not. Okay, there probably there should be a spontaneous onset of labor only. There will be the outcome will be very good. Okay, so we can keep her under ward under strict antenatal service and surveillance and
Yes,
watch
ma'am.
for the spontaneous onset of labor. Okay,
Yes, ma'am.
Will you
so
monitor the
what are
progress?
morning?
By partograph, ma'am.
Yeah.
Partograph has to be maintained.
Okay, you describe in detail how you monitor during the first stage, second stage, and third stage of labor, and also during the antenatal until she goes into labor. You have admitted, as you said, it is a false labor, and how you monitor if she goes into labor beforehand, pre-labor, all first stage, second, third, all stages you have to tell in detail.
Initially, after admitting the patient, we have to see for the contractions if there is any rupture of membranes, ma'am.
Just a basic
So
investigation.
we have
US
to
should
see when she ruptures membrane, what are the
Antenatal,
changes?
antenatal ward, you have to look for the kick chart, and then for spontaneous onset of labor, we do stripping, those sweeping of membranes.
Yes, ma'am.
That all have to be done until she goes into labor.
Okay, ma'am.
Now tell us for the first stage of labor.
On first stage, if that is in case of the latent phase, if the patient in case of primary gravida, if it is more than 20 hours, and in case of multigravida, if it is more than 14 hours, it is considered to be prolonged latent phase, ma'am. In active phase, that is in the first stage, in active phase, it is more than if it is more than 12 hours in primary gravida, and if it's more than 6 hours in multigravida, it is said to be prolonged, ma'am.
When you say patient has gone to active phase,
After 4 cm dilatation, ma'am.
what is the recent change?
As per the WHO care guide, ma'am, labor care guide, it is more than or equal to 5 cm dilatation, ma'am.
Okay.
But in
Okay,
our
so
we are following modified this WHO, ma'am,
what is
partogram.
the difference between WHO labor guide and modified partogram?
The starting of the active phase in WHO care guide, it is more than or equal to 5 cm dilatation, and there is no alert or action line, ma'am. And it has got supportive care with shared decision making. And second stage monitoring is well in labor care guide, ma'am.
Okay. So what is modified partogram? How you do that?
Modified photogram, it is to prevent the prolonged labor, ma'am, with the help of alert and action line. And the active phase starts at more than or equal to 4 cm dilatation with maternal and fetal monitoring. But there is no individualized care given as like in labor care guide, ma'am.
In WHO partogram, yeah, that is labor guide, you start from 5 centimeter. Then when will you assess her next?
Uh,
How labor progress is assessed there? So normal partogram, we take 1 centimeter per hour changes, no? So there, how you will define labor arrest?
Labor arrest is defined as mm, more than or equal to 2 hours if there is no progress.
2 hours or 4 hours?
Ma'am, either if there is no dilatation for more than or equal to 4 hours, in case of good uterine contractions, and in case of inadequate uterine contraction, if there is no cervical dilatation for more than or equal to 6 hours, ma'am.
So that is arrest of labor. Protracted labor is when the progress is going to be slow, then you will call it as protracted labor. So when there is no change, you will call it as arrest of labor. Okay.
Yes, ma'am.
Okay. Then
And based upon the descent of the head, ma'am, if the descent of the head is less than 1.5 centimeter in multigravida, and if it's less than 1.2 centimeter in primary gravida, that is slow descent of head, ma'am. If there is no descent of head for more than
Protracted descent and arrest of descent. இதுக்கு வரும். ஓகேவா? Arrest of labor versus VCS dilatation, arrest of descent. That is the criteria for it. Okay. Okay. How you monitor? Multigravida?
in case of multigravida, the second stage will be prolonged for in case of primary gravida with epidural, there will be more than 3 hours and more than 2 hours. And in case of multigravida with epidural, it is more than 2 hours, and without epidural, it is more than 1 hour. Considered to be prolonged the second stage, ma'am.
Okay. So you know all those criteria. How you apply in the monitoring the patient first stage, second stage, then third stage of labor in case of CPD. So trial of labor.
On applying
Monitor the labor.
Pulse rate, BP monitoring, ma'am.
So how you monitor the descent of labor, descent of head?
on per abdomen and PV, ma'am. On per abdomen, if it is
Both you will do, huh? Both you will do. So initially it will be monitored with the abdominal method, Christian's method of descent of. Okay, is it not? You have
Yes,
to
ma'am.
tell why you are not telling. Okay. Abdominal method, and later on, after full cervical dilatation, you will assess with the vaginal method. Okay. So how frequently you'll do vaginal examination, abdominal
4 hours,
examination?
ma'am.
Abdominal.
Half an hour once, ma'am.
First stage, no detail சொன்னோம் இங்க.
First stage every 15 minutes, ma'am.
That
Second
is,
stage
you
every 5 minutes, ma'am.
monitoring 15 minutes for the, you monitor the fetal heart sounds.
Fetal heart rate,
Right,
ma'am.
So you want whether the patient is taking orally. I want everything to be said, pa. Is it not? How the patient is ambulating.
Hydration.
Adequate hydration, how you maintain?
You have to look for the contractions, ma'am. If the patient is in a dehydrated state, there can be tachysystole, ma'am.
I'm asking whether the patient is can be ambulated, and then whether the patient is taking orally, or you ask her to take orally. Then, what advice you will give? We are conducting a trial of labor, no? As
Yes,
your
ma'am.
definition says, you have to terminate at any time, or any point of time, and there is a fetal distress, or there is, as you have done this protracted descent or a stop descent like that, na?
Yes, ma'am.
How you monitor, or how all the advice you give in the first stage of labor, second stage? I want it detailed.
In the first stage, we can allow her for orals.
Clear liquid fluids, ma'am.
In the first stage, we can allow her for
Have you
clearly.
read the book? Is it given? It was given oral liquids is given. Have you read the book? What they have given?
Clear liquids, ma'am.
How long? Up to how long you can give clear liquids?
4 hours.
Only when the progress of labor is good, you will ask her to take orally. Otherwise, if there is a prolonged descent or the protracted descent or rest of dilatation and all, you have to keep her in nil oral, and you have to supplement with IV fluids.
Yes, ma'am.
So first stage, and when you do an ARM, when you start an symptocinon. So as we have discussed earlier, the spontaneous onset of labor is better for the outcome of the delivery. Is it not?
Normal vaginal delivery. Yes, ma'am.
Yes. Tell me further. First stage monitoring.
Second stage, ma'am.
First stage.
When you do ARM, I'm asking when you do ARM, artificial rupture of membranes. இப்படி சொன்னீங்கன்னா கிளாஸ் இதோ இப்ப 10 நிமிஷத்துலயே முடிச்சுக்கலாம். They have given 2 hours, no? So definitely you have to tell in detail what you are doing, na? You have to tell.
After the patient enters into the active phase, ma'am.
After patient enter into the active stages of labor, ma'am, adequate uterine contraction, if adequate uterine contraction is present, no oxytocin augmentation is needed, ma'am. If adequate
Madam
uterine
asked about ARM, right? ARM, artificial rupture of membranes, madam asked. So what should be the precaution you should take before you do ARM? Otherwise, you'll get one complication.
The head should be engaged, ma'am.
As we discussed, there is an unengaged head. Only the cervical dilatation should be priming. How the dilatation occurs? The effacement, and then only it goes for dilatation. Is it not? So the head won't descend that much. It won't be well applied to the cervix. Is that not? So you have to tell in detail that you will monitor the dilatation every 4th hourly, and I will do a low rupture of membranes and allow the head to sink into the pelvis slowly, and I will make sure that the cord prolapse doesn't occur or the cord prolapse was excluded. Okay, and then only I will take my hands out. Like that, these are the precautions that will be taken, is it not?
Yes, ma'am.
This is the thing you do in your day-to-day life, is it not, in labor ward?
Yes, ma'am.
Yet you have to tell, ma, because it is concerned to our, not like any other cases, na. Simply we'll go for delivery and coming out. Is that not? So, rupture of membranes in active phase we do. Okay, and allow the head to sink. As we have discussed, it is in the brim, as we told, na. Is it not?
Yes, ma'am.
This is the station of the head.
Brim.
Brim தான் சொன்னீங்க. So, அப்போ sink உள்ள போகணும்ல head. Okay.
Yes, ma'am.
Second stage of labor.
Second stage, we have to assess for the duration, ma'am. Whether it is getting for the prolonged labor or that is a good progression of labor, ma'am. If that is inadequate uterine contraction, we go for
What about
augmentation
syntocin?
of.
I'm asking about syntocin, Anna. Syntocin. When you start
If
Inadequate uterine
uterine
contraction,
contractions,
ma'am.
ma'am.
So when the contractions is not adequate and there is a descent, protracted descent or protracted dilatation is there, we will reassess the CPD and then once we'll start with syntocinon. Titration will do depending upon the contractions. So what are the regimens available for the syntocinon infusion?
Contractions.
Regimens available. Upgrading regimen and a downgrading regimen is there. Is it not? You have not read down. Okay. So third stage of labor and then second stage of labor.
What else you will take into account? What else you should be prepared?
Second stage of labor. Do you give episiotomy?
The
சொல்லுங்க
second
episiotomy
stage of
கொடுப்போமா இல்லையா எல்லாத்துக்கும் நானே கேட்ட என்ன இருக்கும் செகண்ட் ஸ்டேஜ் என்ன from the dilatation to delivery சொல்லணும்ல நீங்க சொல்லுங்க
from the first,
whether
we
we
have
give
to assess for the
episiotomy or not
descent of the head, ma'am.
அதான் சொல்லிட்டீங்க எப்படி அசஸ் பண்றீங்கன்னு
Maybe.
சொல்லியாச்சு டிவி பாக்குறோம் போட்டாவர்லி அடுத்தது ஹவர்லி பாக்குறோம் அப்புறம் சொல்லுங்க டிஸ்டன்ட் ஆகுது என்னென்ன ஸ்பேசஸ் இருக்கு செகண்ட் ஸ்டேஜ்ல
We have to look for the
perineal
descent.
phase pelvic phase perineal phase is there okay pelvic phase we'll look for the descent okay and then in perineal phase
Yes, ma'am.
what you do
Bearing effect, ma'am.
பியரிங் எஃபெக்ட் பேஷண்டே இருக்கும் நம்ம என்ன பண்ணணும் தான் நம்ம சொல்லணும் பேஷண்ட் பண்றது சொல்ல வேணும் பேஷண்ட் ஆஸ்கர் டு பியர் பண்ண சொல்லலாம் அப்புறம் எபிசோட்டமி எபிசோட்டமி கொடுக்கணுமா வேணாமா சொல்லுங்க
Episiotomy has to be given.
அத சொல்லணும்ப்பா யூ கமிட் as it is a trial of labor I may expect any time difficulty may arise in delivering of the shoulder I will go for a episiotomy liberal mediolateral episiotomy எல்லாத்தையும் சேர்த்து சொல்லணும் liberal mediolateral episiotomy எல்லாத்தையும் சேர்த்து சொல்லணும் நெக்ஸ்ட் டெலிவரி ஆயிடுச்சா அப்புறம் என்ன எக்ஸ்பெக்ட் பண்ணணும் ஹெட் வந்த பிறகு
PPH, ma'am.
shoulder dystocia expect
Shoulder dystocia can be suspected, ma'am.
What all the factors that helps in navigating this head into the borderline pelvis? What are the factors you will take into account for the navigation of head into the pelvis?
During the onset of labor, the patient will have the giveaway of the pelvis, ma'am. There will be relaxations of the muscles and ligaments, and the head
It is a
will
molding head, ma'am.
Molding of the head
will mold on its own to navigate through, ma'am. And during onset of the labor, there will be there will be increase in the diameter in one plane of the pelvis, ma'am. So it will help in descent of the head, ma'am.
எந்த பிளேன்ல இருக்கும்
somewhere there may be contraction in one plane, ma'am, but this can be overcome by increase in compensatory increase in another plane, ma'am.
Okay. We have not discussed about the criteria to allow for a trial of labor, is it not? Okay. So we'll take into factors of molding and give up the pelvis and the caput succeedum, which will favor for our delivery. Okay. So and then delivery of the shoulders, and then third stage.
Third stage, you have to suspect for PPH, ma'am.
What type of
What you do?
PPH
I'm
you'll expect?
asking how you would conduct the delivery. That's all the question. Expect பண்ணிட்டு கை கட்டிட்டே இருக்க முடியுமா? என்ன பண்ணணும் தான் நான் கேக்குறேன் நான். What என்ன பண்ணுவீங்கன்னு தான் கேக்குறேன். என்ன பண்ணுவோம் தேர்ட் ஸ்டேஜ்ல? எல்லாமே நீங்க பண்றதுல ஏன் சொல்ல மாட்டேன்றீங்க?
What you have to follow?
First stage
I'm still.
அதுதான் சொல்லணும்ப்பா. நீங்க நார்மலா என்ன பண்றீங்களோ அதான் சொல்லணும். எப்படி
Active
சொல்றது?
management of third stage of labor, ma'am.
I will do active management to prevent PPH because I anticipate PPH. I will watchfully expectant to see that whether bleeding is there, further bleeding is there. Okay.
Injection
Follow.
oxytocin.
அப்புறம் fourth stage of labor. Because it is a trial of labor, now what are the complications we expect during labor after delivery? PPH, then
Traumatic PPH or atonic PPH, ma'am. There can be any perineal tears, ma'am.
Anal tears or vaginal tears, lacerations we expect, no? So
Yes,
that
ma'am. So
that
we have
will
to
allow examination of vagina and cervix,
cervix.
and then suturing of all the lacerations to be done. Okay, a patient to be kept in the fourth stage of labor. Okay. So when you say as a successful trial of labor,
The patient has delivered
Vaginal delivery with a good maternal and fetal outcome, ma'am.
okay, accepted. So when the patient delivered by ventos, do you see
Yes,
what
ma'am.
you see? Is it a successful or unsuccessful?
Ma'am, it is successful with trial of labor, ma'am. Either it is delivered by labor natural or instrumental delivery.
With the mother and baby,
Mother and
good
baby.
condition. What is this failed trial of labor?
The patient is taken up for emergency cesarean section.
Or in labor natural, a dead born or a stillbirth, ma'am. Or poor outcome
Or
to
with
the maternal, ma'am.
or with when the rupture uterus occurs, cervical laceration extending to colporexis extending up. What do you say? Is it successful? Only you said fetal demise, you said, na?
Yes, ma'am.
What about this case? If the patient has a colporexis extending upwards, is it a successful labor or a failed trial of labor?
Trial of labor. I mean, that is maternal and fetal comorbidity associated.
Yes, both you have to tell maternal and fetal
And fetal comorbidities, ma'am.
injuries or morbidities, which will have a devastating effect on both of them. We'll say to be failed trial of labor. Okay. Okay.
What are the
all
difficulties?
criteria? Yes, ma'am.
No, ma'am. Continue, ma'am.
What are the criteria to allow her for a trial of labor? First letter number.
It's a singleton pregnancy with vertex presentation with clinically adequate liquor, ma'am. And the patient should not have any comorbidities like GDM, post-dated, GST and severe preeclampsia.
No medical complication. No medical complication. Okay. Then.
Adequate liquor with vertex presentation, ma'am.
Okay. Then, depending upon the criteria over the pelvis, for the pelvis.
Ma'am, it has to be minor degree of CPD at the level of inlet, ma'am, but that should not be of the level of pelvic disproportionate at the level of inlet, ma'am, but there should not be any CPD at the level of mid cavity and outlet, ma'am.
So there should not be any outlet or mid cavity contraction. That has to be excluded.
Yes,
okay. So when you go for a planned cesarean delivery, you won't allow her for trial of labor. What are the contraindications for trial of labor?
Major degree of CPD, ma'am.
Generally contracted pelvis and major the CPD at the level of mid pelvis and outlet. And if the patient is associated with other obstetric maternal comorbidities, and in case of mall presentations and mall positions, ma'am. They can't allow her.
Any scars on the uterus also you should not allow. Any scars, big baby. Okay. Suppose you are this patient, you are allowed for trial of labor, but finally, because you are doing cesarean section, what are the problems you can expect in that during cesarean?
If the patient has gone for prolonged labor, there can be angle extension, ma'am, hematoma,
EPH.
Now the
PPH.
difficulties during delivery of the fetus, na? First, mobile head. Mobile head, na?
Yes, ma'am.
Come from above when there is mobile head. What are the difficulties during delivery of the fetus?
There can
Delivery.
You can deliver a mobile head by LSCS. What are the various ways you can deliver?
Reverse Pattovarthan.
First, mobile head.
we couldn't get no.
In mobile head, how will you deliver? So if you put your hand inside, head will move off. No, so how you can deliver her?
Take the retract. We can use vacuum.
Vacuum better than that? Can you
Can
use
use
forceps? Can you use forceps at the time of cesarean section? You can stabilize the head, deliver the head, or you can apply forceps. Suppose head moves off, then you can catch hold of the baby's leg and deliver as
Reverse
Patwardhan,
Pattovarthan.
ma'am.
Reverse
Reverse
Pattovarthan.
deliver
Patwardhan.
as breech. You can deliver as
Breech.
breech, right?
Yes, ma'am.
Patwardhan is when you have the shoulder at the level of incision. Okay. So if head is mobile and you're not able to catch hold of the head properly, you can catch hold of the baby's leg and deliver as breech. So mobile head delivery is also difficult. Deeply engaged head delivery is also difficult.
Yes, ma'am.
Okay. So how will you deliver deeply engaged head?
Ma'am, we can with the
Push
help of the
the
assistant pushing
push
from
from
the
the
vagina,
vagina.
ma'am,
Hmm.
or by Patwardhan method, ma'am.
Okay. So how will you deliver by Patwardhan method?
On making the incision, first the shoulder is delivered, ma'am, and
Anterior
abdomen, followed by breech, followed by legs, and taking up and the after coming head, ma'am.
Okay. So this is if the back is anterior.
Anterior, ma'am.
Okay. Then
If the back is
any
posterior, we have
method
to
is
go
the
for
recent
breech.
method to deliver deeply engaged head.
We can use forceps vacuum, ma'am.
Forceps, how will you apply? Head is deeply engaged, no? So how will you apply? So one method is one assistant will push the head from below.
Yes, ma'am.
Then you have Patwardhan's method. Any other method by which head can be pushed up? Recent advances. So a pillow. So a silicone tube will be put beneath. If you inflate it, it will slowly displace the head up.
Okay,
You have never
ma'am.
heard about fetal pillow? So you should know about recent advances also. Recent advance paper you have no?
Yes, ma'am.
If you are planning for planned LSCS, so major degree CPD, you will go for planned LSCS. So at what gestational age you want to do that?
39 completed weeks, ma'am.
So what you should take precautions before doing that?
We have to look for the kyphosis and scoliosis, ma'am. If it's associated with any spinal deformities, there can be associated respiratory compromise, ma'am. So you have to get clearance from thoracic medicine side, and then you have to go for elective C-section, ma'am. And there can be
Suppose she is having any deformity, then you have to anticipate problems in anesthesia and other things,
yes,
and
ma'am.
respiratory problems, so you have to get opinion. But when you are planning LSCS at 39 weeks, what are the checklists you should satisfy before you do? First thing, what you should do? You should reconfirm our dates, right?
Yes, ma'am.
So you should reconfirm whether the dates are correct before you plan elective LSCS. So it should be done around 39 weeks.
Yes, ma'am.
So to prevent this going for a cesarean section, What
Yes,
are the
ma'am.
methods? What are other methods we can try for vaginal delivery? Trial of labor. Apart from trial of labor, that means that we have to wait for the spontaneous onset of labor, is it not?
Yes,
So when
ma'am.
you suspect a mild delivery of CPD, what are the other method we can do? Go for? We can go for an elective
Trial.
induction or near term. Okay, we can go for elective induction at or near term. Okay, so yeah, your patient is have taken treatment for 3 years, is it not?
Yes,
And
ma'am.
also a short period of 3 years of infertility was there. Okay, so in those cases, what is the syndrome you will expect?
Dystocia syndrome, ma'am.
Okay.
Short
Short,
What are
stature, male distribution of hairs with
short stature, is short, obese, stocky female with the male distribution of hair with the bull neck, ma'am. With short thighs and broad
broad shoulder.
shoulders. You can suspect this kind of,
Pelvis.
ma'am. The pelvis will be
what is the
suspect.
difficulty in during labor? What are the difficulties in marriage during labor?
Difficulties. There can be prolonged labor, ma'am.
Android
Mm.
pelvis.
Mm.
And this dystocia syndrome, women will have android
Android
pelvis,
pelvis,
ma'am.
ma'am.
So they can go for deep
Deep
transverse arrest and
transverse.
obstructed labor, ma'am.
Okay. So when you assess a pelvis, we have assessed the CPD. When you assess a pelvis,
Assessment of pelvis.
there are types of pelvis is there, no?
Yes,
Yes,
ma'am.
ma'am.
How many types of pelvis is there?
There are four types of pelvis, ma'am.
Four parent types of pelvis. Four parent type of pelvis. Any four parent types. Okay. So the anterior half, what it is, or the posterior half, what it is. Posterior half tells about the type of the pelvis. Anterior half tells about the tendency of the pelvis. Okay. So these four can occur in any number of combinations. Okay.
Okay, ma'am.
Okay. So four parent types were there. So we name them.
Gynecoid pelvis, android pelvis, anthropoid pelvis, and platyploid pelvis, ma'am. In gynecoid is
Okay.
most commonly 50% male seen, ma'am. In gynecoid, it is sacral promontory is not reachable.
Which is more common? So gynecologist.
Gynecoid,
Gynecoid,
ma'am.
ma'am,
50%.
Next
50%.
common is the
Anthropoid, ma'am.
anthropoid.
25%, ma'am. And 5%
5%
of android
android
and
and
5% of
5%
platyploid
platyploid.
pelvis.
Okay. In which the ethical groups these pelvis are common?
Ma'am?
And Negroes, what type of pelvis will occur?
Negroes, tall
In
stature.
Europeans, any particular
Europeans,
type neighbor? Caucasians,
and
Europeans,
anthropoid.
you just go and verify now all these questions. Okay. So when
Yes,
you assess the pelvis,
when will you assess the
pelvic
pelvis?
CPD assessment we do in 38 weeks, in
38
35
weeks, ma'am.
completed weeks. When you assess a pelvis, it's like that kind of or and like that.
That has to be assessed during the onset of labor.
Any time the pelvis can be assessed at any point of time. Okay, whether she's pregnant or not, we can assess the pelvis. But CPD assessment, as we have discussed earlier. Okay. So
Okay,
what are
ma'am.
the features of an android pelvis? இது முடிச்சிட்டோமா நம்ம இந்த சிபிடி இதை முடிச்சிட்டோமா?
Ma'am?
All about CPD we have finished.
Mm,
Mostly covered, ma'am. What are the other abnormal type of pelvis?
Negli's pelvis and
Robert pelvis, ma'am.
What are they?
Nagel's
Nagel's
pelvis
pelvis
is
is
absence
absent
of one
one
ale of
ale.
the sacrum, ma'am. If the both ale of the sacrum are absent, it is Robert's pelvis, ma'am.
Generally
What is
contains
asynclitism?
Asynclitism is the normally engaging diameter in the fetal skull is bipedal diameter, ma'am. If it's A super subparietal diameter as the engaging diameter. It is asyncretism.
What is anterior? What is posterior?
In anterior asyncretism, the anterior parietal bone will be going in front, deep into the pelvis, ma'am. In case of the posterior,
Wait. The anterior is also the asyncretism is so the sagittal diameter, it won't engage along that of the transverse diameter of the pelvis. So the sagittal diameter of the fetus, either it goes anteriorly or posteriorly, which is said to be asyncretism. Okay. So when the suture goes anteriorly, what will be the presenting part?
posterior parietal
Posterior
bone.
presentation will be there. So it is called
Posterior asyncretism, ma'am.
posterior asyncretism. Which bone is presenting? It is called posterior asyncretism. Okay, so when the sagittal sutures goes backwards, what will be the presenting part?
The presenting part will be anterior parietal bone.
Anterior parietal bone. It is called anterior
Anterior
asyncretism.
asyncretism.
So in primary, what is common? In multi, which is common?
Posterior asyncretism is more common in primary gravida, ma'am. Anterior asyncretism is more common in multigravida, ma'am, which is more favorable, ma'am.
Okay, so the posterior parietal presentation helps in early engagement of the head so that the baby goes into the pelvis early. So it occurs more common in the primates. Okay, whereas anterior asyncretism, as anterior parietal bone presentation, it will occur because of the baby is falling forwards and pendulous abdomen. The baby will be falling anteriorly so that the baby will have a delayed engagement of the head. Okay, so
Yes, ma'am.
the anterior asyncretism is common in case of multi.
Multigravida.
So this is the special type of the engagement occurs in case of the flat pelvis. Okay, as you have told now, super subparietal presentation.
Diameter.
Super subparietal diameter. What is the diameter?
8.5, ma'am.
8.5. Okay, so this by this extreme asyncretism, what is the name given to that anterior and posterior asyncretism?
Posterior asyncretism is Naegele's obliquity, ma'am.
Hmm.
Anterior asyncretism is Littmann's obliquity, ma'am.
Lisman's obliquity. Okay, so in what are the mode of delivery in case of flat pelvis? So by this extreme asyncretism, the head negotiates into the pelvis. Okay, by rocking movements, the head negotiates into the pelvis. Okay, what is the how the mechanism of labor in flat pelvis? What is the mechanism of labor in flat pelvis?
Extreme asyncretism.
That is the engagement only, extreme
Extreme
asyncretism.
asyncretism, ma'am.
Yeah. So the engagement occurs with a extreme asyncretism and engaging diameter is the super subparietal diameter. And then the internal rotation occurs deep into the pelvis. Okay. The level of outlet only the internal rotation occurs. But where in our gynecoid pelvis, where the internal rotation
The
occurs
level
at
of
the level
the
of
ischial spine, ma'am.
ischial spines. So in the mid pelvis, in the pelvic cavity itself, it will occur. But whereas in the flat pelvis, it will occur at the level of outlet and then the head will be delivered. Okay. So what is the mechanism of labor in anthropoid pelvis?
The diameter is anteroposteriorly elongated, ma'am. Anteroposteriorly oval. Occipital posterior.
Anthropoid pelvis, what is the pelvis diameters?
Anteroposteriorly
At the
oval, ma'am.
inlet, the cavity and outlet. It will be Anteroposteriorly oval.
It will be
Anteroposterior
oval.
diameter is more than that of the transverse diameter. Okay, the head engages either in the anteroposterior diameter or the occipital anterior
Occipital
or in the
posterior.
occipital posterior positions will occur. And then comes the internal rotation where it will occur.
Internal
The
rotation.
diameter is of the pelvis is good. Okay, they will go for an extreme rotation anteriorly and deliver by the occipital deliver and okay, or else it will go for a persistent occipital posterior and then how the baby will be delivered.
Face to
Face to
pupils.
pupil.
Face to pubis delivery will be occur and thereby more injuries may occur to
Injuries.
the maternal soft tissues. Okay. So what is the mechanism of labor in android pelvis?
That is,
Deep transverse.
there will be no internal rotation taking place, ma'am. It will go for deep transverse arrest, ma'am.
Because of its funnel shaped nature, there won't be any mechanism of labor. The head won't deliver at all.
Yes, ma'am.
Okay. So there, if at all, head will get arrested at the level of ischial spines
Deep.
because of its funnel, because narrowing of the outlet and the cavity. Okay.
Yes, ma'am.
So these were the mechanism of labors in various types of pelvis.
Okay, ma'am.
Uh, what all the factors? What all the other factors that helps that causes abnormality of the pelvis? Sacrum, like sacral factors, as we had discussed, no anomalies of the pelvis and all.
In case of
Rickets
rickets,
pelvis.
it will be
And
in
about the lumbar spine, lumbar spine. What is high assimilation pelvis? What is low assimilation of pelvis? High
in
assimilation
case
pelvis and low
of rickets,
assimilation
it will
pelvis.
be the
Anomaly
inlet will
from
be reniform shaped, ma'am.
rickets. We are not having rickets at present, no.
It is
So
rare.
our exposure to sun is good, and we have very good vitamin D. The rickets is very rare. Okay, so where the patient doesn't, where the women is growing in environment that is not exposed to sunlight, the rickets will occur. Osteomalacia and rickets, the rachitic pelvis will be occur. Okay, what is the rachitic pelvis shape? Shape of the rachitic pelvis? It will be reniform shape. Okay,
Right.
peaking of the sacrum will be there. Okay, I'm asking one about another thing. What is high assimilation pelvis? What is low assimilation pelvis?
Yes.
What is sacralization of the lumbar vertebra? Lumbarization of the sacral vertebra.
Ma'am, highest.
Sacrum will have 6 vertebrae, ma'am, in high assimilation
This
pelvis.
causes narrower, more rigid brim, ma'am.
Mm.
In case of low assimilation, it will be shallower type of pelvis.
No,
Shallower.
it is not. It is the high assimilation pelvis. Sacralization of the lumbar vertebra is there. What is the depth of the pelvis? How it is assessed? What is the length of depth of the pelvis? It is about 10 centimeters. Okay, it is from the
So,
pectineal eminence to the ischial tuberosities. It's about 10 centimeters. Okay, only the baby has to go through this only 10 centimeters. In case of high assimilation to the pelvis, because of the lumbar gets attached to the sacrum becomes very lengthy, no? It has to travel 1 more 2 centimeters. Okay, so there will be a prolonged labor will be there. Whereas in the lumbarization of the sacral vertebra, only 4 vertebrae will be there, one will be left to the lumbar. So the depth of the pelvis is very less and then the baby goes through it easily. Okay, so this is the impact on the delivery of the fetus. Okay. Mm. How you measure the subpubic angle? What subpubic
by,
angle?
by inserting the two fingers below the subpubic arch,
Subpubic angle, that is subpubic arch. Subpubic angle.
angle should be measured by placing the By making an eye in our fingers and keeping it over the arch, ma'am.
You show in the camera.
Like this, ma'am.
So it should be
Placing
Divergent
the
control.
it should be like this, or 90 degrees, above more than 90 degrees. Okay, subpubic angle. When it is narrow, it is like this. Okay, like two fingers, less than acute angle.
acute
So it
angle.
Android type of pelvis. Okay, subpubic arch, subpubic arch.
Subpubic arch is measured by inserting the two fingers inside, ma'am. If it
That should
accommodates
accommodate
the
the
fingers,
subpubic arch should accommodate two fingers. Okay,
yes,
and then
ma'am.
outlet diameter, intertuberous diameter.
Ma'am, sacrotuberous diameter by admitting the
Intertuberous diameter.
by admitting the knuckles, ma'am. If it admits 4 knuckles, then it is adequate, ma'am. More than it's equal to more than 10 centimeter. If it does not admits 4 knuckles, it is said to be contracted, ma'am. If it's less than 8 centimeter, then it is said to be contracted pelvis at the level of outlet, ma'am.
Okay, what do you define by the anatomical contraction for contracted pelvis?
Anatomical contracted pelvis is if there is shortening in more than or equal to one dimension and more than or equal to one plane of more than or equal to 1 centimeter, ma'am. Then it's said to be anatomically contracted pelvis. If
And
there is
obstetrically contracted pelvis?
if there
When you
is
say
a change in the shape and the size of the pelvis, which will interfere with the delivery of the normally average sized baby.
interfere with the mechanism. இப்போ
Mechanism.
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 இப்போ நம்ம சூப்பர் சப்பாரேட்டர் சொன்னோம்ல, எக்ஸ்ட்ரீம் ராக்கிங், எஸ் இம்ப்ளடேஷன், ஸோ அதெல்லாம் கூட தான் வரும். So in which interferes with the normal mechanism of labor, it is said to be anatomy, obstetrically contracted pelvis.
Pelvis.
Okay, when you go for a trial of labor, only what are the criteria should be there?
When the
Uterine contraction, ma'am. With baby, adequate size of the baby and adequate liquor.
with vertex
Vertex
presentation,
presentation.
ma'am. No maternal comorbidities.
Comorbidities.
And contraction, there can be a borderline CPD at the level of inlet, ma'am, but there should not be any contraction at the level of mid cavity and outlet.
So your patient now coming with the history, as you have the abdominal pain with the PRY, can you allow her for a trial of labor? Your patient, 39 weeks trial of labor with borderline pelvis.
Early rupture of membranes.
Is one of the contraindication. Okay, so membrane should rupture only in the after the active phase of labor. Early rupture, there is no
Suspected to be.
the failure of trial of labor will occur. Okay.
Okay, ma'am.
Karthika, no?
Yes, ma'am. Mostly all
Questions?
part of CPD has been covered, ma'am.
All parts of this.
Recent advances, you should know about role of ultrasound, intrapartum ultrasound.
Intrapartum ultrasound. What are the diameters you will see, and when you will, what are the methods by which you do ultrasound for assessing during intrapartum?
Biparietal diameter, ma'am. Position of the head is
What are
deep.
you say the methods by which, what are the transabdominal, transvaginal, like that? There is methods of doing ultrasound.
Transperineal.
Transperineal and transabdominal ultrasound helps in evaluation during the labor. Okay. What all the diameters you will assess?
Biparietal diameter, ma'am. The position of the head, ma'am. Deflexed or L-flexed head.
Where you have made this?
So you can do the position of the head, you can make out. Then what else you can make out?
Station of the head can be assessed, ma'am.
Then station of the head also
Station
you can make out. How you can make out station of the head?
Then
Is there any cap overriding of the
rotation of the head can also be assessed. So there are diameters to assess the distance between the symphysis and the sagittal suture, and how far it is rotating, the other discrepancies. So There are diameters there. You go and read, verify. Okay. There are 4 diameters to see this assessment. Abdominal and also transperineal methods are there. Transperineal method helps in when the pelvis and head is deep into the pelvis, whereas transabdominal method before it goes into labor or the early labor it will help. Okay. So these were the methods by which we can assess the progress of labor and also any rotation. Okay, so when the patient goes into deep transverse arrest, when you define what your definition for deep transverse arrest?
Ma'am,
Sagittal to the transverse diameter.
Ma'am, there is no descent of head after the level of ischial spines with the sagittal suture at the transverse plane, ma'am.
What is the treatment for that?
Cesarean
Emergency
section.
C-section, ma'am.
So now in modern obstetrics, C-section. No deep engaged deep transverse arrest, we don't go try for a rotational delivery and all. Okay.
Yes, ma'am.
Okay, a few points about the obstructed labor. Okay, in obstructed, how you diagnose the obstructed labor?
We can see the bandles ring parabdominally, ma'am, which is extending from below upwards. And the patient will be having contractions without any relaxations in between.
Proceed.
There will be thickened upper segment and thinned lower segment, ma'am. There can be bleeding per vaginum. And
How the
laceration.
mother will look like? How the mother will look like?
Mother will go in for tachycardia and peripheral cold and clammy, ma'am.
Dehydration will be there. The starvation ketoacidosis, tongue will be furred, look will be there, or urine output will be concentrated. Okay, so and then abdominal examination, there may be bandle string, but nowadays we are not getting this type of obstructed labor. Okay.
Vaginal examination.
Excuse me, ma'am. Ma'am, we have half an hour more, ma'am. We have another case presentation also, ma'am. Thank you, ma'am.
Okay. I congratulate CMCH PGs for presenting nicely. Wonderful
Where
presentation.
is the case presentation? Where is the case presentation? In another group, huh?
Ma'am,
Priyanka has to present now, ma'am. She's also having another case, ma'am.
So we are continuing with the class, the same class.
Yes, ma'am. She is having another case presentation, ma'am.
Okay.
Yes, ma'am.
You proceed. Proceed.
Thank you, ma'am.
Good evening, ma'am. A 26 years primary mother coming from Padapai PHC, studied up to 8th standard, housewife belonging to class 4 of socio-economic status, booked and immunized at Padapai PHC, ma'am. Primary, her last LM menstrual period was 15/5/2025 and estimated delivery date is 22/2/26. Gestational age was 39 weeks, ma'am. Booked and immunized, come to OPD for safe confinement, ma'am. History of presenting complaints, no history of abdominal pain, no history of bleeding per vagina, no history of draining per vagina, no history of burning micturition, no history of swelling of legs or blurring of vision, ma'am. Her menstrual history, attained menarche at 13 years of age, a regular menstrual cycle length were 28 days, not associated with pain or clots, ma'am. Last menstrual period is 15/5/2025, ma'am. Marital history, married since 3 years, non-consanguineous marriage, and spontaneous conception of delivery, ma'am. Obstetric history, present pregnancy, first trimester, confirmed by UPT at 50 days of amenorrhea, booked and immunized at Padapai PHC. First trimester urine pregnancy cord test done at 8 weeks and it's positive. Pregnancy confirmed by USG. No history of excessive vomiting, fever, radiation exposure, or no bleeding per vaginum or abdominal pain, ma'am. history of folic acid intake present. Dating scan done which corresponds to her gestational age.
மா
No history.
பிபிடி போடலையா நீனு? எக்ஸ்கியூஸ் மீ, பிபிடி போடலையாம்மா?
PPT தான் ma'am போட்டிருக்கேன்.
பிபிடி இல்லையா? சரி, ப்ரெசென்ட் பண்ணு.
மேம்
ஓகே,
பிபிடி வரலீங்களா மேம்?
எனக்கு வரலையேப்பா.
PPT is not visible. You have not shared, I think.
சித்ரகலா ஷேர் பண்றீங்களா கொஞ்சம்?
எஸ் மேம்.
எல்லாம் ஒண்ணுத்திலே போட வேண்டியதானே அடுத்தடுத்து? நீ தனித்தனியா போடுறீங்க, லேட் ஆகுதுல. ப்ரெசென்ட் பண்ணுமா, லேட் ஆகுது.
ஓகே மேம்.
Show the NST, ma. Show the NST in the camera at least. Show the NST in the camera. At least we'll see that.
சரி ஸ்ருதிக்கு ப்ரெசென்ட் பண்ணுங்க பிரியங்கா. ஸ்ருதி will make the arrangements na for sharing the slide.
Yes.
Okay. Present பண்ணுங்க. It's there. Going. Half an hour time is there na. You present. Start presenting. Priyanka, start present பண்ணுமா.
Ma'am. Second trimester, quickening felt at 20 weeks of gestation, ma'am. Iron, folic acid, and calcium tablets was taken. Anomaly scan done at 22 weeks. No obvious fetal anomaly or growths are normal. Liquor was adequate. No history of blurring of vision, headache. HIV VDL HPSAG was negative. In third trimester, perception of fetal movements present. History of iron and calcium tablets intake is present. No history of abdominal pain. No history of bleeding per vaginum. No history of draining per vaginum. Growth scan was done. It is found to be normal, ma'am. Past history, no history of diabetes mellitus, hypertension, asthma, TB or epilepsy. History of hypothyroidism since 2 months of gestation. Patient taken Thyronorm 50 micrograms once daily, ma'am. No history of blood transfusion. No history of previous surgery. No history of drug allergies, ma'am. Personal history, normal bladder and bowel habits, ma'am. General examination, patient moderately built, afebrile, no pallor, no pedal edema, no cyanosis, no ictus, no lymphadenopathy, bilateral breast normal, thyroid not enlarged, spines normal. Height was 138 centimeter, weight was 47 kg, ma'am. Weight gain in last 1 month is 2 kg. Her BMI was 24.7, ma'am. Pulse rate is 82 per minute, regular, normal volumes, no radial femoral delay. Blood pressure 110/70. Measure at right arm sitting position, ma'am. Respiratory rate 14 per minute, ma'am. Cardiovascular S1, S2 had no murmur. Respiratory rate bilateral, normal vesicular breath sounds, no other sounds. Nervous system, no focal neurological deficit. In abdominal examination, inspection, abdomen longitudinally enlarged, umbilicus everted, stria gravidorum and linea nigra is present. No abdominal wall edema, no scars or no sinuses. Hernial orifices are free. Palpation, fundal height corresponds to 32 weeks of gestation, flanks full. Symphysive fundal height is 34 centimeter. Abdominal girth is 90 centimeter, ma'am. Fundal grip, a soft, broad, non-palatable mass felt at the fundus, probably breech. Lateral grip, a smooth, curved, uniformly resistance felt on the left side, probably its fetal spine. Multiple nodules felt on the right side, probably its limbs. First pelvic grip, a hard, round, independently palatable mass felt in the lower pole, probably head. Second pelvic grip, a first pelvic grip was confirmed, head is mobile. Clinically, Liker adequate. Auscultation, present fetal heart rate present in the left spino-umbilical line, 134 beats per minute. It's regular, ma'am. Summary, at 26 years, Mrs. X, primey, with booked and immunized, and EDD was 22 to 26, come with the OPD with 39 weeks of gestation. On examination, present with a single live cephalic presentation with good fetal heart sounds, with contracted pelvis with CPD major, ma'am, admitted for safe confinement, ma'am.
So when you admit a patient, if you suspect a CPD, major type of CPD.
38 weeks completed weeks, ma'am.
$38 completed weeks.
Yes, ma'am.
What are the complications you expect in case of major CPD? Antenatal period.
Yearly rupture of membrane, ma'am. Cord prolapse. Possibility of PPH, ma'am.
Okay, after admission of 38 weeks, how you do go for antepartum surveillance?
Fetal heart rate monitoring, ma'am. Strict FKC monitoring,
Heart
ma'am.
rate அப்ப நம்ம பார்த்துட்டே இருப்போம் காலையில இருந்து சாயந்தரம் வரைக்கும். What are the antepartum surveillance we do in our antenatal ward? Heart beat பார்த்துட்டேவா இருப்போம்? How you say like that? So on admission, what all investigations you will do?
Basic investigation, ma'am.
Complete blood count.
Complete blood count. Renal function test, liver function test.
Why you want to go for liver function and renal function test? Why you want to do liver and renal function test?
Madam was asking about antepartum fetal surveillance. So how we are going to assess the fetal well-being and maternal well-being?
You have to otherwise the fetal well-being. எப்படி பார்ப்போம் fetal heart sounds பார்ப்போம் எப்படி பார்ப்போம் I will do modified biophysical profile அதான் சொல்லணும் நீங்க first on admission அதான் கேக்குறேன் what all the investigations you will do in when you admit a patient. So first I will do the investigations for a CBC and you want to do RFT LFT because she may go for I plan for an elective LSCS and then for assessment I will do the substantiate பண்ணும் நீங்க என்ன சொல்றீங்களோ அதை substantiate பண்ணும் ஓகேவா
Okay.
and then I will go do an ultrasound. In ultrasound as a PG you definitely should answer this question.
Doctor.
Amniotic fluid index, ma'am. அதுக்கப்புறம் Doppler studies, ma'am.
You will do Doppler. What is the indication for doing Doppler? For CPD, Doppler helps.
Biometry. What about the fetal biometry? You want to look about the DPT, HC, abdominal circumference. Fetal biometry constitutes the parameters of the fetus. Okay, then only comes the liger and then comes the placenta. And what is necessary for doing for a Doppler? We plan for delivery, na?
Yes, ma'am.
Then why you want to go for Doppler? Is any complication you say?
No.
Normal growth fetus? No, there is no indication for Doppler here. Okay, first you do a fetal biometry. I look for the head circumference and I will confirm the estimated fetal weight that you have calculated already, na?
Yes, ma'am.
With ultrasound, I will confirm the estimated fetal weight. Like that, you have to tell.
Okay.
And what is antepartum fetal surveillance you do while the patient was in antenatal ward?
NST, ma'am.
Only NST is enough, Papa. Modified biophysical profile சொன்னல நான் சொல்லணும் எல்லாத்தையும் சேர்த்து தான் சொல்லணும்.
Okay.
ஏப்பா கம்முன்னு இருக்கீங்க சொல்லுங்கம்மா.
Modified biophysical profile வந்துட்டு AFI and NST monitoring is done, ma'am.
Yes. Then day to day what all you'll do? Or What are the instructions you give to the PG and staff nurse?
Strict FKC monitoring, ma'am. If leaking PV,
If the patient
Patient
complains
always
of
of
pain
urine
or
or leaking PV.
draining, ma'am, we have to tell the patient about the possibility of the cord prolapse, ma'am.
You are planning cesarean for this patient, right? Because she is having major degree of CPD.
Yes,
Yes,
ma'am.
ma'am.
Okay. So what are the precautions you will take before you are planning a planned LSCS?
Adequate blood products, ma'am.
Hmm.
We have to rule out the spinal deformities. No, we have to rule out for the spinal deformities, ma'am.
Hmm.
We have to get the clearance from the thoracic medicine site, and anesthesia clearance has to be obtained before taking the patient for elective LSCS, ma'am.
Okay.
Ma'am,
Introp.
uh,
What are the problems associated with elective LSCS?
the patient, if the patient is having short stature, that can be also associated with short neck, ma'am. There can be difficult intubation from the anesthesia side, ma'am. And if it is associated with the spinal deformities, there can be decrease in the respiratory reserve, ma'am.
Okay.
Obstetric concern, the சொல்லுங்க anesthetic நம்ம நம்பலாம். You go for obstetric concern. And what are the merits and demerits
Mobile
of going for cesarean section? What are the merits and demerits going for an emergency cesarean section? Okay, you have to discuss in that way. Not going for an difficult intubation for mother and all. We are not anesthetists. We are an obstetrician.
Not all patients are having spinal deformities, right? Short stature doesn't mean they will always have spinal deformities.
What is the merits and demerits of elective cesarean section? Madam is asking, what are the demerits? We discuss பண்ணணும்.
Because of the mobile head, the head delivery will be difficult, ma'am.
Okay.
Angle extension.
What else?
Angle
How will be the
extension.
lower segment of the uterus?
Those
Lower segment will be formed or not well
the
formed.
segment will
Those
not be
not
that
formed,
formed,
ma'am.
ma'am.
So if it is not formed well, what are the problems you can expect? What will happen? Floor segment is not well formed. So delivery of the baby will be difficult. So you may have to extend the incision. Sometimes incision can get extended up. PPH also can taken up, no? So thinned out lower uterine segment, delivery will be easier, bleeding will be less. So bleeding will be more. When you do a planned elective LSCS, bleeding may be more. Plus, patient is not already in labor. So atonic PPH chances are also more with elective LSCS. Right? When patient is in labor and you're doing section, chances of atonicity is less. Okay, so elective section, chances of atonic PPH is more. Because lower segment is also not well formed, so bleeding will be there from the lower segment. Those complications you will expect in elective.
Yes,
Okay.
இப்ப இதான் சொல்லணும் சரியா elective cesareanல demerits இதெல்லாம் lower segment not well formed and the patient may not in labor so the uterus atonicity will be there. Okay, one about the baby, there may be a more chances of transient tachypnea of the newborn. So okay, so these were the complications of elective cesarean. Whereas what are the very good thing about the elective cesarean section? Everyone will be aware, and anesthesia is well prepared, and the team is well prepared, and blood will be reserved, and patient is also well prepared in empty stomach. Okay, is that not okay? So what is the merits and demerits of emergency cesarean section? So this patient, sometimes we can go for emergency cesarean section. Okay, so what are the merits and demerits of the emergency cesarean section? The patient is not well prepared. Okay, the team is not well advanced prepared. Okay, and then more chances of injury extension may be there. Okay, and then there is senior obstetrician may not be hand holding. Okay, what is the merits of that? Good thing maybe there.
Delivery will be easy, ma'am.
Okay, so as she is in labor, there is less chances of TPH, and then the baby is well mature. It's significant. So the labor signals comes from only the baby, na? Is it not? So the TTH, the transit tachypnea of newborn is very
Yes.
less compared to that of the elective cesarean section. Okay, so these were the merits and demerits of the emergency and elective cesarean section. When you allot a patient for emergency cesarean section, so we are admitting a patient. Okay, we'll keep her under observation and we'll do the cesarean section once she goes into labor. We will allot some patients like that. So whom and all come to under this category? யாருக்கெல்லாம் நம்ம இந்த மாதிரி எமர்ஜென்சி போச்சுன்னா நம்ம பார்த்துக்கலாம் எல்எஸ்எஸ் பண்ணிக்கலாம் rather than elective cesarean section சொல்லுவோம்.
மைனர் டிகிரிஸ்
யாருக்காவது அது மாதிரி சொல்லுவோமா?
மேஜருக்கும் சொல்ல மாட்டோம்.
மேஜருக்கு சொல்ல மாட்டோம். ஆனா மேஜருக்கும் சில சமயத்துல சொல்லுவோம். எப்போ? அதுக்காக தான் நான் டேட்ஸ் பத்தி கேட்டேன். I asked about dates. No? When she has bad dates and the reliability of the dates is not there, and fetal maturity is there, but we are not convinced. So, okay, 34 weeks short stature, the baby will be also small, na? We are not sure of her dates, and the baby maturity, the fetal biometry doesn't correlate with her dates. So, in those cases, we will allot her for emergency cesarean section at the onset of labor, so that we are very sure that the baby is mature and the baby have attained its expected age. Okay, so these patients will be categorized. So only I asked for the days in the the start of the class. Okay. So you want to take one X-ray. So what X-ray you will prefer, and what all the inferences you will get from the X-ray to assess the CPD? We are going back to our old way.
Erect lateral view X-ray, ma'am.
What all the inferences that will be got from that X-ray?
Limbs.
Any limb deformities, any fractures in the pelvis, ma'am?
CPD assessment தான் கேக்குறேன் நான். limb deformities க்கு pelvis lateral view சொல்லிட்டோம். pelvis lateral view ல limb deformities க்கு சம்பந்தமே கிடையாது. Okay. What all the inferences that will be got from the lateral view? Okay. So in case of limb deformity, what is the difference in the height of the limb that will have an impact on the pelvis? Difference in the height of the limb.
More than 1 to 2
height of the limbs.
More than 2 inches, ma'am.
Inches. 1 to 2 கிடையாது. More than 2 inches.
More than 2 inches, ma'am.
More than 5 centimeters. So, and the more than 2 inches will have an impact on the fetal pelvis. Okay. So, lateral view ல நமக்கு என்னென்ன inferences இருக்குன்னு ஒரு 6 இருக்குது. அதை படிச்சுக்கோங்க. 6 inferences we can get from the lateral view. Okay. This is another theory. Obstructive labor cesarean பண்ணும்போது what are the difficulties we may encounter?
Ma'am, the lower uterine segment will be very thinned out, ma'am.
Angle extension.
Angle extension.
Bladder will be
edematous, ma'am.
What is that called? The obstructed line is called, what is that?
Bandles.
Bandle string. So the bandle string will be at the level of umbilicus. So it demarks the lower segment and the upper segment. So the bladder will be drawn to that level.
Yes,
so on
ma'am.
opening the abdomen, lower we go for usually transverse incision, no? So the upper limit of the lower uterine segment cannot be reached. So in case of obstructive labor, where there is a well-established bandle string, we can go for a midline or an RPM incision. Okay, and that so that the bladder reflection will be at the level of umbilicus, and we have to go from above, push the bladder down. So the bladder injuries are very common. Okay, and the incision, lower segments. And then we will be encountering the deeply engaged head difficulties, delivering of the baby in the deeply engaged head. Okay. Can we go for a trial of labor in case of previous card uterus?
You have to ask for the history, ma'am. For what indication the LSEs were done? LSEs was done, ma'am. If it is because of
Trial of labor. Trial of labor in mild CPD.
previous card uterus, no, ma'am.
No, அப்பதான் நம்ம சொன்னோம் நம்ம பார்த்தோம்ல no, there should not be trial of labor for CPD in case of scarred uterus. We can go for trial of labor for a scar. Trial of labor for scar can be done in case when there is no CPD. But in case of mild CPD, there should not be a trial of labor in case of a scarred uterus. Any questions? And the participants, any questions you can ask?
Ma'am, if there are no questions, can we conclude the session, ma'am?
Ma'am, there is a quiz, ma'am.
Yeah, we'll do that after thanking the judges. I thank Dr. Tenmuri ma'am and Dr. Kartika ma'am for taking time from their busy schedule. And it was a really elaborate and detailed discussion, ma'am, on cephalopelvic disproportion. I think the PGs will now be very confident in facing the exam. Thank you for covering all the practical points so beautifully, ma'am. Thank you so much. We'll now move on
Any
to the
questions from the other faculty? Anbarasi and Sugar.
Yeah, ma'am. Any questions, ma'am?
Any questions from your side?
Ma'am, we are having a set of questions now, ma'am, for the quiz, ma'am.
If it's okay, we'll move on to the quiz now, ma'am. Shall we do that, ma'am?
Conclude.
Okay. Thank you so much, ma'am.
Thank you for giving this opportunity. I thank Fox, Dr. Umayal madam.
Shall I launch the first question, ma'am?
Valuable interaction with this speeches. Thank you, one and all.
Thank you, ma'am. Thank you so much, ma'am.
Thank you,
Thank
ma'am.
you, ma'am. Thank you, madam. I am Dr. Vijayalakshmi, madam. Thank you, madam, for coming and giving the speech on the PGs. Thank you so much.
Thank you, ma'am.
Chitra sister, can you post the quiz PPT?
Yes, ma'am. We will be launching the questions from the Zoom, ma'am. Each question we will be giving 30 seconds time. I request all the participants to submit the answers. First question. I guess you can all see the pop-up on your screen.
You will have a time of 30 seconds. You will have time of 30 seconds for each question. And the first prize awardee will be given a prize in the upcoming conference.
Case presentation mentor vertical.
Last 5 seconds, I request everyone to submit the answers.
Submentor Brettmatic phase extension.
I want everyone to submit the answers. Only few people have submitted. Last 5 seconds. Time up. Second question. I request all the participants to submit the answers actively. Last 5 seconds. Timer. Third question. Last 5 seconds. Timer. Fourth question. Last 5 seconds. Timer. Fifth question. Last 5 seconds. Timer. Sixth question. Last 5 seconds. Timer. Seventh question. Last 5 seconds. Timer. Eighth question. Last 5 seconds. Timer. Ninth question. Last 5 seconds. Timer. Last question and 10th question. Last 5 seconds. Time up. Thank you.
So we'll need around 10 minutes to process the quiz results. In the meantime, we'll have a short presentation on energy sources in laparoscopy. Is my screen visible?
No.
No, ma'am.
1 second.
Ma'am, at first open the PPT, ma'am.
Yeah.
Yeah, and then minimize it and come to Zoom. Click on share.
I'm trying. Yeah, that's what I'm trying to do.
Yes, ma'am, we can see your screen now. Yes.
Okay.
But not the PPT. Yeah, we can see, ma'am. Thank you.
Okay. So we'll start now. So this will be a very short presentation on energy sources in laparoscopy. Basically, all the things that you need to know about the different energy sources and how to choose the correct energy source for the correct surgery and what are all the complications. So before we go into the classification of energy sources, let us see what we need the energy sources to do. We basically need them to do 4 things. That is cutting the tissue, coagulating and sealing vessels and tissue dissection. So these are the 4 things that you want the energy sources to do. So now you need to know the different types of energy sources and their advantages and disadvantages. Okay, so we have energy sources that uses electrical energy. They are called electrosurgical devices. So under this, we have monopolar, bipolar, and advanced bipolar. And then we have energy sources that uses ultrasonic energy, like the harmonic scalpel. And then we have hybrid devices that uses both electrical energy and ultrasonic energy. Okay. So this is the basics of how a monopolar and a bipolar works. So we all know this. Let's just brush it up a bit. Okay. So you all know that in monopolar, we have a generator that generates the electrons. This current will pass through the active electrode, as you can see in the picture, and it will reach the patient tissue. And then it will come back through the patient return pad, and then it will go through the return electrode and back to the generator. So this is what happens in a monopolar. Whereas in a bipolar, the current travels only between the 2 tips of the forceps. So in monopolar, the current flows through the patient and then to the return pad, whereas in a bipolar, current flows between 2 tips of the forceps. So there is a grounding pad used in monopolar, but no grounding pad is used in bipolar. Monopolar can be used for both cutting and coagulation, whereas bipolar can be used for precise coagulation alone. And monopolar devices are available in the forms of hook, spatula, and needle. We'll be seeing that in the subsequent slide. And bipolar, the advantage of bipolar, since the current flows only between the 2 tips of the forceps, there is very less risk of stray current injury. Whereas in a monopolar, there are more chances for stray current injury and cautery burns and chances of injury to the intraperitoneal structures also. Okay, so what is the frequency that we use in the electrosurgical devices? So 350 kilohertz to 3 megahertz is what is ideally used during the electrosurgery. Normal household appliances use around 60 hertz, and when the frequency touches 100 kilohertz, the neuromuscular stimulation is stopped. Okay, so you can see in this picture how cut and coagulation works in a monopolar. So in the left picture, you can see that in pure cut, there is passage of low voltage and high frequency current. The generator is 100% on. Whereas on the other end, under coagulation, you can see that there is discharge of high voltage, low frequency current. Here, the generator, that is the current flows on only for 6% of the time and it is off for the 94% of time. In between the cut and the coagulation, you have something called blend. Blend 1, 2 and 3. Blend refers to both cutting and coagulation. Now, the picture on the right shows the effect of cut, blend and coagulation over the tissue. As you can see, coagulation causes more damage to the tissue and more collateral damage and thermal spread when compared to cutting. So, what does that mean? When you use pure cut mode, when you activate pure cut mode, it means you are activating low voltage, high frequency current. Here, the cell membrane fractures and the cytoplasm bursts out. Whereas, when you activate coagulation mode, here we have low frequency, high voltage current. Here, this heat inside the cell is causing the coagulation of the protein, which is causing shrinking of the lumen of the arteries. So, you have to remember two things. Under cut, you have two modes. One is pure cut and the second is blend cut. Pure cut means it only cuts the tissue, there is no coagulation. Whereas blend cut refers to both cutting and coagulation. And under coagulation, we have to remember two things. One is fulguration, the other is desiccation. What is the difference between fulguration and desiccation? Fulguration means coagulation at a distance. Distance refers to the distance between the electrode, active electrode, and the tissue will be 0.5 to 1 millimeter. This type of coagulation is used for used in endometriotic spots. Whereas desiccation refers to coagulation with contact. It is used for sealing the vessels. So under cut, you have pure cut and blend cut. Under coagulation, we have fulguration and desiccation. Okay. Another thing that we have to know is whenever we are cutting or coagulating a tissue, the amount of burn produced depends on three things. One is the intensity of the current. Second is the time for which we activate the current. Third is the area that we hold between the electrode. The intensity maximum should be 40 watts. Sorry. The time for which you activate the current should be 3 seconds. And the area that you hold, area of that is the tissue that you hold should be less than 6 millimeter. If you have to coagulate or cut a tissue more than this, then you have to activate the current in intervals. That is 3 seconds at one time and then you give a break and 3 seconds at the second time and then 3 seconds at the third time. Okay. And what do we know? What should we know about the patient return plate? So it has to be placed on a vascularized muscle mass and we have to avoid bony prominences and we have to place it close to the incision site and the size of the return plate should be minimum 100 square centimeter and all the metal ornaments should be removed from the patient's body. Okay, so as I told you already, the role of energy device, tissue cutting, vessel sealing, coagulation and tissue dissection. All this together will help you to reduce the operative time. Okay, now moving on to the different energy sources. So we will now discuss 5 to 6 energy sources with the pictures so that it will be easy for you to identify. I'll give you short points on what is the advantage and the disadvantage and what instrument should be used for which type of surgery. This picture now shows a monopolar hook. As you can see, the tip is a L hook here. Okay, as I told you already, monopolar devices are available in the forms of hook, spatula and needle. On the left side, you can see the L hook. Okay. And below that, you have the other end of the instrument, which will be connected to the cable. You can see it has one pole. So monopolar instruments will have one pole on the cable end. This picture on the right shows a monopolar spatula. You can see the difference between the hook and the spatula. Both uses monopolar energy. As told already, monopolar can be used for both cutting and coagulation. The disadvantage with monopolar is that there are more chances for overshooting and more chances for lateral thermal spread and hence injury to the adjacent structures. Next is the bipolar. You can see different types of bipolar instruments here. The first is a bipolar Ruby instrument. Second is a bipolar Maryland. Third is a bipolar fenestrated grasper. The main thing you have to see in the bipolar is that the current will travel only between the two tips of that instrument. You can see a orangish yellow colored plastic that is separating the two tips of the forceps. Okay, so that it prevents the current to flow in between the tip of the forceps. Okay, and you can see the cable end on the right side of the picture. It shows two poles. Whereas in the monopolar instrument, it had only one pole to connect to the cable. Here it has two poles in a bipolar. So the advantage of bipolar is that the current travels only between the two tips of the forceps. So there is less thermal spread, less chances for injury to the adjacent structures. But the disadvantage of a traditional bipolar is that it can be used only for coagulation. You cannot cut with a traditional bipolar handle. Okay. Now, coming to the third thing, that is the advanced bipolar. So, advanced bipolar, under advanced bipolar, we have several things. First thing is a vessel sealer. Okay. So, you can see the picture here, vessel sealer. It is an insulated handle. You can see the two tips of the forceps. It looks like a bipolar only, and the current travels between the two tip of the forceps here also. So, but here, the difference when compared to a traditional bipolar and advanced bipolar is that apart from coagulation, it also helps in cutting the tissue and it also gives you good hemostasis. So you don't have to change instruments for cutting. So this will provide you coagulation, cutting and hemostasis. Next is another advanced bipolar, which is LigaSure. So LigaSure is nothing but the trade name for advanced bipolar instrument. But what is the difference between a LigaSure and other vessel sealers is that LigaSure operates on tissue response method. That is, this generator has a tissue response system, meaning to say, this will assess the tissue and it will decide the amount of current needed to coagulate the tissue, and it will also give you a audio feedback once the coagulation is done. Okay, you can see this instrument here. It has a handle. When you approximate the handle, this tissue will this tip of the forceps will grasp the tissue. Okay, and then you can activate the current. At the end of the coagulation, the generator will give you a audio feedback. It will give you a ping sound to let you know that the coagulation is complete. And another advantage of LigaSure is that you can also choose to double coagulate a pedicle, double coagulate a long pedicle with vessel, like the uterine artery pedicle. Okay, so it gives you audio feedback once the coagulation is complete so that there is no overcooking of the tissue. And it also gives you the option to double coagulate the long pedicle. And another advantage of LigaSure is that it has a blade for cutting. And this blade can only be activated when you press the cut button. Okay, you can see in this picture, above the lever, you have a ash color small button. That button is for activating the blade. So once you are sure that you have double coagulated the uterine pedicle, you can choose to cut now. But that is not the case with the vessel sealer. Okay, vessel sealer simultaneously coagulates and it can also cut the tissue even before you confirm that the coagulation is complete. So that is the main advantage of LigaSure. Because of the tissue response system, you can know that when the coagulation is complete, and you can also choose to double coagulate, and it has a blade for cutting, which can be activated only by pressing the cut button. Okay, so you can be sure that the coagulation is complete before you choose to cut that tissue. Okay, so it uses advanced bipolar energy, and it is better for sealing vessels up to 7 millimeter. That is why we can use it for coagulating the uterine artery pedicle also. Okay, and it has this blade for cutting, and it gives very less collateral damage. So that is about advanced bipolar, where we saw the vessel sealer and the ligashure. Next is the harmonic scalpel. Now we have covered all the devices that uses electrical energy. Now we are going to see the harmonic scalpel, which uses ultrasonic energy. So this is a mechanical energy. Okay, so that is the main advantage of harmonic scalpel. Since it uses mechanical energy, there is very less thermal spread, very less injury to the adjacent organ. So this picture shows you the harmonic handle, and it also shows you the harmonic unit. As you can see, it shows two settings, minimum and maximum. In this picture, the minimum setting is at 3 and the maximum setting is at 5. And you can see in the handle, you have a lever for grasping the tissue, and above the lever, you have two buttons. The small button is minimum setting. The bigger button is the maximum setting. We'll discuss what is what now. Okay. So since this uses ultrasonic energy, it acts on high frequency mechanical vibration. So how does this actually work? In this picture, you see the transducer. This transducer has piezoelectric crystals. This will generate the ultrasonic energy, which will cause this blade to be activated. So this blade is the active jaw, and you can see the above one, the Teflon jaw, which is the inactive one. So what does this blade do? It will undergo high frequency mechanical vibration. Okay, when you keep it in minimum setting, it will vibrate at 15,000 rate. When you keep it at maximum setting, it can vibrate at 55,000 rate. Okay, so you can see the lever for grasping the tissue. You can also see the button for activating the energy. Okay, so the maximum temperature here will only be 80 to 100 degrees centigrade. Whereas when you compare it to the electrosurgical devices, the temperature will be 200 to 300. So you can understand there will be less tissue necrosis here and less collateral damage. So this is very better for tissue dissection. Okay, here there will be protein denaturation that occurs because of this high frequency mechanical vibration, and this will lead to sealing of the vessels, and there will be reduced surgical smoke. So what is the advantage of harmonic over advanced bipolar is that there is less tissue necrosis and less collateral damage. But when you compare ligashure and harmonic, ligashure is very, very better for vessel sealing, whereas harmonic is very better for tissue dissection. Okay. Okay, so active jaw, as I explained already, this will be the vibrating blade. This should always be kept under our vision. Okay, whereas the inactive jaw or the Teflon jaw can be kept towards the sensitive side, like towards the bladder, towards the ureter. And when I explained the minimum and maximum setting already, and this harmonic scalpel has the adaptive tissue technology, which will recognize the soft tissue and hard tissue, and it can decide the power of energy that is needed for coagulating that tissue. Okay, so since I told you already, harmonic is better for tissue dissection. It works under ultrasonic energy. Whereas ligashure works with advanced bipolar energy, and it is very good for vessel sealing. So they have come up with a newer energy device called the Thunderbeat. This Thunderbeat has both harmonic and vessel sealer in the same handle. So it uses both ultrasonic energy and bipolar energy. So it is better for both tissue dissection and vessel sealing. Okay. Okay, this table gives you a nutshell the comparison between ligashure, harmonic, and Thunderbeat. So energy is advanced bipolar in ligashure, whereas it is ultrasonic energy in harmonic. In Thunderbeat, it uses both energy. When comparing the vessel sealing capacity, ligashure can seal up to 7 millimeter, and Thunderbeat also can seal up to 7 mm. Harmonic can seal only up to 5 mm. And the thermal spread is low in ligashure and Thunderbeat, but it is very low in harmonic. And the cutting speed is moderate in ligashure, and it is fast in harmonic, and it is very fast in Thunderbeat. So what you should understand is, since ligashire is very good with vessel sealing, it is typically used in long pedicles. And since harmonic is better with tissue dissection, it is used mainly in fine dissections. Since Thunderbeat has both these qualities, it can be used for both sealing and for dissection. Okay, so we have discussed all the energy sources. You should know what are all the complications of electrosurgery. The main thing is thermal injury to the bowel and ureter, and there can be insulation failure. We have seen all the instruments. You have seen that the monopolar, bipolar, vessel sealer, everything was insulated completely. Whenever there is a break in the insulation, or you call it insulation failure, then it means the energy can break through, or it can travel through the insulation break points also, meaning to say it can injure the structures that come into contact with the break points like the bowel or the ureter. And there is something called direct coupling and capacitive coupling. I'll explain it in the next slide. Okay, here in the first picture, you see that there is an active electrode with an insulation defect. Okay, so there is passage of current to the adjacent structure, which is the bowel, leading to bowel injury here. Whereas in the next picture, you can see that the active electrode is touching the telescope. Okay, so which is another metal. So there is accidental contact with another non-insulated tool that allows passage of energy to the non-insulated tool also. Now this telescope is in contact with the bowel. So this is resulting in a bowel injury. So when there is accidental contact with other non-insulated tool like a suction apparatus or a needle holder or a telescope, then it can cause direct coupling injury. Now what is capacitive coupling? Now when you are using metal ports and you are using active electrodes through the metal ports, sometimes current following through the hook will induce current in the metal port. This current can dissipate via the abdominal wall and it can damage a intraperitoneal structure also. This can be avoided by using plastic ports, but the risk is very high with hybrid ports. Hybrid ports means it has both metal and plastic parts. So to avoid capacitive coupling, you have to use plastic ports. That is the takeaway point here. Okay, so after learning all about the different energy sources, you should know the safety principles. Okay, always visualize the active tip, be it the monopolar hook or spatula or a bipolar or a vessel sealer. You always have to visualize the active tip and then only activate the energy. And you always have to use lowest effective power. And the activation times you have to keep it short. Okay, and you always have to inspect the insulation before using the handle. Whenever there is an insulation break, you should not use that handle. And always make sure you maintain distance from the vital structures. Okay, how to choose the energy device? Now that we have known, now that we have learned all the advantages and disadvantages, you should know, you should be able to summarize now. Whenever the need is fine dissection, for example, like staging, laparoscopic staging, nodal sampling, you need fine dissection. Then harmonic is the choice. And when you want to coagulate and cut large pedicles, like in a TLH, then you have to go for ligashire. When you need both dissection and sealing, then you go for Thunderbeat. And for general cutting, like ovarian drilling, for cystectomy, for cutting the vault in simple TLH, you can use a monopolar hook. Okay, so what is the take-home message? You always have to understand the energy physics. Thereby, you can improve the surgical safety. Only when you understand how a monopolar, bipolar, advanced bipolar works, then only you can know the complications and you can improve the safety. And different devices have different purposes, like ligashire, harmonic, and traditional bipolar. You should know the need. What do you need in that particular step, and you have to choose the handle accordingly. Okay, and we always have to know the complications. You have to know about thermal injury, insulation failure, direct coupling, capacitive coupling. That is how only when you have the knowledge, you'll be able to prevent the injuries. You always have to follow proper technique to avoid injuries and to ensure patient safety in laparoscopy. So that is it about the energy sources in laparoscopy. If you have any doubts, you can ask now, or we can go to quiz results.
Thank you, Dharani. That was a very short and clear presentation. You gave us a very great insight into the electrophysics of energy sources.
Thank you, ma'am.
Chitrakala quiz இது சொல்றீங்களா?
Yes, ma'am. Results are ready, ma'am. Results are ready, ma'am. I will display them.
Yeah.
Can you see the screen, ma'am?
Yeah, we are able to see. So the winner is, I think it's Dr. Shruti. Is it Shruti?
Yes, ma'am.
Okay, first winner is Shruti and the second winner is Kanimori. So the first winner will be getting a prize in our annual Cox conference.
So congratulations, Shruti, for getting the first prize. And thank you everyone for attending the session. Thank you, Suganya ma'am and Anbarasi ma'am for organizing. Thank you.
Thank you.
Ma'am, would you like to discuss the quiz questions, ma'am?
Shall we just read out the answers very fast? Can
Yes,
you display
ma'am.
it? Yeah, the first question is AP diameter of engagement in phase presentation is both the submento-pragmatic and submento-vertical. Next question. Next question.
Yes, ma'am.
What is true about plane of greatest dimension? It is the most roomy plane. Third question. Assessment of CPD is by all the three methods: CT pelvimetry, clinical examination, and the third one, X-ray pelvimetry. Fourth question. Landmark in skull are all except these are all not the landmarks of skull. Next question. Distance between a point below one parietal eminence to a point above opposite parietal eminence is super subparietal diameter. Next question. Next question. In Grove presentation, the attitude of head is partially extended. Next question. Obstetric conjugate is diagonal conjugate minus 1.5 centimeter. Next question. All our methods of assessing CPD except all the answers given are methods of CPD assessment. So the answer is none of the above. Next question. Curve of Caris is related to anatomical pelvic axis. Next question. Importance of plane of least pelvic dimension is all except it forms the upper boundary of obstetric inlet. Okay, that is, these are the answers. Okay. I thank Dharani and thank Tenmuri ma'am and Kartika and Mayal ma'am and Vijay ma'am for the case presentation. Thank you. We'll wind up with the session.
Okay, ma'am.